So now for the lecture. So we are so excited to have Dr. DiBlasio here today. He is here to speak to us about ICU delirium. Thank you so much for joining us here tonight.
Thank you for having me. And everyone here, this is a two. They said there's the number, the thing on the first one if I want to increase the volume. But if you can hear me, I'll leave it like this. My name is Fred DiBlasio. I'm the director of critical care at Huntington Hospital. I've been there for, how long have I been there? 12, 13 years? My wife is here. She also works at Huntington Hospital, but not in the ICU. She's worked pretty much everywhere else. So I know all the nurses here are from a variety of different places across Long Island. Some Northwell, some non. St. Francis is here, and Peconic Bay I was talking to somebody from, and Brookhaven. Now it's called Long Island.
Long Island Community Hospital.
I saw that at the amphitheater they have this time
Yeah.
there. And so I'm going to guess that a lot, if not all of you, are involved with some sort of delirium assessments and ABCDEF type protocols, and everybody's at different stages of trying to do these things, right? So something that has, I don't want to rat out my people from Huntington, but something that has been a little more difficult than the other elements, some of them, is the delirium assessment. And so this is perfect. I've done this for medical residents or family practice residents also, but I made the lecture better because I think it's a different audience, and it's probably a different set of things that we need to address here, because they're not going to work in the ICU, but you guys all do. So let me just see if this works for. No. Did it work? Oh, there we go. It's a little delay, maybe. So I sent these objectives to Christine a while ago. So we want to understand the clinical well, everyone can read, but diagnosis and characteristic details of delirium, and know how to identify the populations at increased risk, because then we'll know who to look at. Learn to identify the common causes of delirium, because then we can try to eliminate them. Understand the best strategies to prevent delirium, and also know the current treatment modalities that are being used. Now, I did write a brief book chapter on this like 6-7 years ago for the ICU, what is it called? 5-minute consult critical care that came out a couple years ago. It was like a 2-page, 3-page thing, and it basically summarized a lot of these things, but the things are all basically still relevant. Let's see if I do this one. So delirium is a neuropsychiatric syndrome, and it's sometimes called acute confusional state or acute brain failure. And many medically ill patients are often suffering from this and are misdiagnosed with other things, and they wind up not doing so well. And why is it important for us? All of us who work in the ICU, we see these patients who are subject to developing this, who do develop this, and who suffer. And probably for 20, 30, 50 years, it hasn't been really recognized as a specific entity that can be avoided, can be treated. Oh, you know, it's great the patient lived, right? It's great the patient lived. They made it through the ICU. They go on the floor. What happened to them afterwards? I don't know what happens to a lot of my patients now, as far as after they leave the hospital, after they go to the floors and they go to rehab and things. But from what I'm hearing, a lot of things aren't as good as they could be. And so, being so common, you know, one of the 6 leading causes of preventable conditions in hospitalized elderly patients, you know, the patients who do develop delirium, they wind up doing tremendously worse than those who don't. And I've seen it firsthand with patients. I've seen it firsthand with friends of family that I've seen come through the hospital, and not come through the ICU necessarily, but be in the hospital. I go to see them a couple of days, all of a sudden they're wacky. And this is people that I know from outside the hospital, and they're as normal as can be, you know. And so it can happen to anybody. It doesn't even have to be an ICU patient. And there's tremendous documentation and literature that supports that there's very long-term complications for these patients. Cognitive dysfunction. If the person's an accountant before they get delirium, they may not be able to go back to being an accountant again. They may not be able to go back to being a lawyer anymore. They may not be able to do the crossword puzzle anymore that they used to do before. And this is, you know, for a few months, a few years, maybe indefinitely. So 40% of the patients who develop delirium have some cognitive dysfunction at 3 months, 5 years after an episode. I mean, this is long term. This is not something that, oh, they'll snap out of it once they get back home. So there really is something that we need to recognize so that we can intervene and that we can prevent this from happening, or stop it once it's noticed as quickly as possible to prevent these long-term complications. And these are the percentages of people who leave the ICU who develop delirium and leave the ICU, and these are the sequelae that occur. I mean, there's a bunch of different studies. You can find different numbers for these things, but it's a rough estimate. I think you get the idea. And the patients that get this, 50% of the patients who are on a ventilator who develop delirium, 20-25% of the lower severity ICU patients. So, I mean, it's a significant amount of patients. And so what is delirium? And I have to say that there were much better videos on YouTube than I could come up with in the basement with my video camera. So I stole a couple things to try and really illustrate. And if you know these things already, let me see here how we can do this. Where's the microphone on this thing? Yeah, you can't hear it, huh?
I want to get out of here.
Mr. Williams.
I want to stay here.
Mr. Williams, I'm the nurse practitioner.
There we
Barb, remember me from yesterday?
No, I don't.
You're in the hospital. You're in the hospital.
Get me out of here.
Let me get your glasses for you.
Delirium is a sudden onset of confusion that can happen when someone becomes ill. It can happen at any age, but those most at risk are the very young, the very old, and the very sick.
Delirium. I was told I had that, and I was very confused. I misinterpreted a lot of things in the environment, sounds. I would hear sounds in the walls, and hindsight's always clear. I knew it was oxygen, and I called my sister and like, you have to get me a hammer. I've got to let the birds out of the wall.
A person with delirium cannot think clearly, has trouble paying attention, and is not aware of what is going on around them. Delirium can cause a person to see or hear things that are not there, but seem very real to them. Treating delirium as soon as possible is extremely important to a patient's recovery. Care providers do not know your family member as well as you do and may not recognize behavior changes right away. It is critical for family members to make staff aware when they see changes, such as unusual sleepiness or lethargy, extreme restlessness or agitation, inability to recognize family or relatives, confusion about where they are, saying strange things, resistance to medical care. Delirium is very stressful for patients and can slow down the recovery process. The sooner it is recognized, the better. 40 to 60% of hospitalized patients may experience some form of delirium. That is why it is so important for families to inform staff when they see something that is different.
Does anyone have a sort of video like that, or some kind of delirium tool that they have, or pamphlet that they have for the family members at their hospital when they come in? Nothing that the literature that the families can read, or okay. So diagnostic manual of psychiatry has defined this as a disturbance of consciousness with reduced ability to focus, sustain, or shift attention. That's one of the hallmarks, right? So the disturbance develops over a short period of time and tends to fluctuate during the course of the day. So it fluctuates. That's one of the other main signs. Develops acutely over hours to days after the patient gets to the hospital. Fluctuates again, and the ones that are highlighted are obviously the important ones. And the reduced ability to maintain the attention. And our gentleman in the video, he had the agitated form delirium, as probably everyone recognized. But there's also a different type of delirium that we'll go over in a second here. Yes, sundowning. That's fluctuating attention. Well, it depends how they present there with the attention. But yes, that's very similar, or the exact same thing depending on the scenario. But yes, and you just call me Fred. That's fine. Okay. So they may have difficulty word finding, inability to write. And I don't know if you ever given an ICU patient a thing and they just go like this and they're right off the edge of it and they think they're telling you something. Speech disturbances with slurs or mumbling, incoherent and disorganized, memory dysfunction, The short-term memory, you have to tell them the same things over and over again, obviously. Disorientation to place and person, place, and time. Misinterpretations, illusions, paranoia. They can't copy a pentagon. So types of delirium, there's the hyperactive or hyper alert like our gentleman had there. He was getting ready to rip everything out and run out of the room and wants to go home. So he's easy to identify because he's the one who's going to get all the attention. Then there's the covert ones that have hypoactive delirium. They're like sleeping all the time, very somnolent, unable to sustain your attention when you wake them up. They really don't want to be bothered by what you're saying. They're not eating. And these are the ones that probably fall by the wayside a lot because they're not the attention getters. And then there's a mix. Okay. So just some other populations, and there's statistics galore that you can find. They had some different ones in the video, but approximately 50% of post hip fractures can develop delirium, 40% of hospitalized greater than 65, 30% of patients in surgical intensive care units, 20% of patients on general medical wards, 50% in general surgical wards. A big problem. And why do they get this? It's very multifactorial. Most of our patients possess the risk factors: medication, systemic illness. Who do you have admitted to the ICU that doesn't have medications or systemic illness? They're elderly as well, most of them. So this is a clever mnemonic there. I watched death. I thought that was... Yeah, so infections, withdrawal, acute metabolic disturbances, trauma, pain, neurologic syndromes, hypoxia, thiamine and B12 deficiencies, hypothyroid, parathyroid hormone, hyperglycemia, hypoglycemia, vascular issues, toxins, heavy metals. That's I watched death. Non-mnemonically, they have infections, electrolyte abnormalities, endocrine dysfunctions, liver failure, hepatic encephalopathy, pulmonary disease with hypoxia, cardiovascular diseases. Now, some of these can be weeded out and treated differently. So obviously, if the patient has hepatic encephalopathy, you can treat that as a separate entity, but they can still be more predisposed to developing delirium on top of that because of the fact that they're already off their game from the initial liver failure. Anticholinergic drugs, and there's actually quite a list there, right, that you don't think about. Analgesics. Analgesics are a big one. Everyone knows that. And benzodiazepines are notorious for causing this. Also, Benadryl is a nice one because everyone thinks that makes you sleep, but I don't know. I've taken Benadryl a few times to try to make me sleep, and it actually makes me kind of jittery more than sleeping. But the same thing it does to patients, especially the elderly. And anticonvulsant medications, antihistamines, antiarrhythmics, antihypertensive, antidepressants, antimicrobials. We don't really have much that doesn't cause it. Additionally, so what you're probably figuring out here is there's not many patients who aren't at risk here. 60 years of age, male sex, visual impairment. They can't see what they're doing. They can't see what you're doing. They can't hear what you're doing. They can't. Major medical illnesses, hip fractures, we said, metabolic abnormalities, polypharmacy. UTIs, Foley's, right? Everyone always says the Foley's. It's the first thing they pull out. But there's some things that we can definitely rule out of these patients that can, or not necessarily rule out, but that we can fix, and the patient may get better. Wernicke's, encephalopathy, hypoxia. These things can be simply fixed. Hypoglycemia, hypertensive encephalopathy. Things that you treat them and the patient will get better. Wernicke-Korsakoff is basically a thiamine deficiency, and it's everyone associated with alcohol withdrawal, but people can get it without alcohol withdrawal as well. But alcoholics are prone to it because they're thiamine deficient, because they don't really eat well. But it's a continuum with Korsakoff syndrome, and Korsakoff is basically, from what I understand, it's a more permanent thing. The Wernicke's can definitely be treated with thiamine supplementation, which is what we give a lot of our alcoholics when they come in. So you have to have these things in your mind when you're seeing these patients that are very bizarre also. Hypertensive encephalopathy is another one that patients come in all the time. They're on 10 blood pressure medications. They're taking none of them. Their blood pressure is 280, and they're confused, and and you say, oh, they have dementia. But if you get their blood pressure down, and they turn out that they have hypertensive encephalopathy, and really this is a diagnosis of not exclusion, but a diagnosis of when you treat it, it goes away. That's how you know that you had it. So if you get the blood pressure under control, then maybe mentation may improve. So as far as the pathophysiology of delirium, it's not well understood. There's a lot of research being done. A lot of it's being done in Vanderbilt University in Tennessee by Wes Eli and his team of, or Ellie, I don't know how you pronounce it, but his team of physicians there. And a lot of the original research has been done by them documenting this in a lot of the critical care medicine articles. But it's a reversible impairment of cerebral oxidative metabolism and neurotransmitter abnormalities. So it's up here, right? Anticholinergic receptors and acute confusional state because of the impaired neurotransmitters. Also dopamine excess, increased serotonin levels, inflammatory responses, increased cytokines because the patients are ill. Changes in blood-brain barrier permeability because the patients are ill. Inflammation causes. Stress reaction and sleep deprivation, which all the patients have in the hospital for the most part, because they get stuck at 5 in the morning with blood, they're awakened at 10 p.m. for their meds, their finger stick at 2 a.m. So the majority of them are sleep deprived. Anyone have sleep like preservation type programs where they're not doing things between like certain times in the night? No? Okay, we're trying to work on some sort of. You doing that?
Yeah, try to, know alarm, don't go in, don't be disturbing if you can help it, the alarms don't go off and stuff.
Yeah, we have some kind of like quiet hour type
Quiet hours,
things
we call
also.
it, yeah.
At 10 o'clock, there's a loud voice overhead that announces it's
Yeah.
quiet time now.
Yeah.
And then 5 minutes later, it does it again.
Dull the lights, try to sleep.
So, I mean, I'm just going to skip through that, but here's what we want to get to here. How to evaluate a patient with suspected delirium. Everyone knows what CAM ICU is? All right. So, as not being the person who does it, I'm not that familiar with it. I went through a few things about it, but I know that when we developed it, I was highly involved with that, remember? Yes? Okay. So we were doing that, and then they started to do it in the rest of the health system, which was great because now I have the support of everybody in the entire health system to help us do that. So basically what you need to do is establish a baseline for the patient. If you don't know the patient how they were before, you can't say that how they are now is different, right? But you could probably get an idea that they were in seeing spiders and stuff before, and weird things on the ceiling and sounds, trying to smash hammers into the wall to get the birds out, like the lady in the video. But if you, so they say it approaches, you speak with the family and you see what the patient was like at home. Oh, this guy was 92 years old, but he was still driving, and I don't want to be on the road with him, but he was driving, and he was doing the crossword puzzles every day, and so you didn't get to establish a baseline. This guy was perfectly fine, and now he's just balled up in the bed in some sort of state where you can't get anything out of him. He just pulls everything away when you try, and and so you realize that there's a difference there. So, or the same thing. I have a family friend who was in her 60s. She came in and she has very bad uncontrolled diabetes. She's had some toes amputated and things, and she was in our step down unit. Wasn't even in the ICU, and she was getting treatment for infection there. I came in to see her, and she thought we were at her house. She was wondering what I was doing there, things like that. It's just very obvious that from the functional status that she has outside, doing all the supermarket shopping, paying bills, and everything else, faded. So, you need to know how they were, what the time course was for the change, because we said it fluctuates. It doesn't just and it's a relatively short period of time. It's not like over 6 weeks you develop delirium. It's over a few hours, a few days, and it goes back and forth. In the morning they could be fine, and in the evening they're sundowning, like you're saying, and they're thinking that, you know, you're in the garage working on the car or something like that. You know, just something unusual, very bizarre to you, but to them it's 100% real. So you look at the time course. Then you want to review all their medications once you have a suspicion for that they're delirious. But all the things we went through, which basically every medication that they possibly could be taking is possibly a trigger for delirium, but the specific ones, the pain medicines and the benzodiazepines, I think if you start with those, you try and eliminate those from the regimen that aren't needed, because not every patient who lifts their head off the pillow needs to be sedated again. So basically, you have a lot of patients who are on a lot of benzodiazepines, like how, and you know, they're telling us about the opioid crisis on one hand, and then we're giving patients 5 milligrams of morphine every 15 minutes for, you know, so you have to be judicious with it and understand that these things have further effects than just, you know, a little sleep for the patient now and things. So try to eliminate the benzodiazepines, try to eliminate any narcotics that the patients are taking, especially if they're not used to it from before. Some of these patients, they come in, obviously they're on fentanyl patch, they have, you know, OxyContin, like 30 milligrams every 4 hours, and you know, that's how they drive around town. So basically, those people, if you take it away, you might cause a problem. But you know, the patients who are opioid naive, it's like a 85-pound lady who just had a hip fracture. Now you're giving her dilaudid PCA pump, and she's franking on that thing. So you don't be surprised when later on and then she says, "Oh, can I have something to help me sleep?" You know. So you know, you have to be aware of the things that we're doing, and I'm not saying the nurses are doing it. I'm just saying that, you know, it's that they're you know, the doctors are ordering these things, and it's there for the patient to be used, but you have to sometimes be a little judicious about it. And also, you know, this history of drug and alcohol dependence, I mean, it's a lot more common than I would like to think. But then when you actually talk to people, you know, they drink how many beers every night, they don't think that that's funny, you know, to hear something like that, just like, you know, 8 to 10 beers a night or something like that. Or, you know, they use recreational drugs. They may not tell you, but, you know, it's much more common than you think. I've been reading the Suffolk County police blotter lately, and basically there's about 3 robberies a week, and the rest is about 5 pages of alcohol while driving, drugs while driving, like 25-year-olds. It's just like, if you've never read it before, you can take a look there. Would be very surprised to see the amount of drugs. I went to a town meeting on Tuesday, Huntington town meeting. There's an opioid epidemic going on, and they're thinking about ways to combat this, and it's so bad that they're thinking of building a high school just for recovering heroin addicts. Yeah, apparently this works in other states. So my point is, it's very, very widespread, and they start with pills, and so a lot of people are on things that they don't tell you that they could have problems with once they get in. And you have to think about that as something rather than just, you know, they're sick. And review all the diagnostic studies, make sure the labs are reasonable, you know, a high creatinine, a high BUN, you know, acidosis, high ammonia levels, things that are pretty common. They can be causing the mentation issues. Baseline function, any psych history. You can do the mini mental status exam, but it's not necessarily for delirium, right? It's like this whole thing of doing serial 7s and spell world backwards. They want you to, I think that's where the thing on the bottom, that's what is it, a pentagon? Yeah, so draw the pentagon. So, I mean, these are things that you can ask to see the patient's mental status, but it's not specific for delirium. They've come up with a much more sensitive one and relatively easier to do from what I can tell. So we have the CAM ICU, and I think pretty much everybody has the same cards that look like this, right? I don't know where this came from, but I know ours are very similar to this, and you know the steps are the same, and so you want to determine the acute onset or fluctuating course, the inattention, altered level of consciousness, disorganized thinking, and you give them a score, and then you're either positive or negative. So you know, I won't say where this happens, but I sometimes go to the bedside and I say, is the patient CAM, is patient positive or negative? And they'll say, well, kind of, I think, maybe, but then I have to keep reminding them because it's basically, you either are or you're not, because there's four things there, and you make a score. So you're either positive or you're negative. There's no like, well, I think, so, and I think that's the way everyone's supposed to be doing it, right? Yeah. So I don't know how it goes other places, but I find there's a lot of exclusions sometimes, like, oh, this patient has this and this and this, and really they're not the exclusions. The exclusions are very, very limited exclusions if we want to be real about doing this and doing the best thing for our patients. Because we have this other thing that Society of Critical Care Medicine created probably 15, 20 years ago, the fast hug sheets. Is anyone familiar with that? And basically it's a list of things, that's a check sheet that basically to make sure that ICU patients are getting certain appropriate things that have shown to improve outcomes, like feeding, are they getting analgesia, of course it's eluding me now, but are the Foley's getting evaluated for removal, are the central lines getting evaluated for removal? It's a bunch of things like that. Is the head at 30 degrees, are they getting GI prophylaxis if they're appropriate, DVD, things like that to prevent missing. So we go through this with the nurses every day. I added the CAM ICU onto that, and so every day we go to the ICU nurses, and as a team we go over all these categories and check, yes, we did this, okay, yes, we did this. Oh wait, they're not on DVT prophylaxis? Okay, let's figure something out for that. So we don't miss anything day to day, and then the nurses sign off on it for us, so that shows that it was a collaborative effort. But we added the CAM ICU on there, and it still really hasn't come to the point where we go down the list and everybody is either yes, no, and it's appropriate and it's accurate. So it's a work in progress, and I know it's not an easy thing to do, but this is something that can really benefit the patient, so I think we'll have to press on. Anybody else having that kind of problem? Yeah. Yeah, you're doing it in the morning and in the evening. We're doing that also. No, we're only doing it once a day? They're scoring it once a day. We only do the fast hug sheets once a day, though. Okay. We round twice, though. So here's a list of some of the simple exceptions here. Validated assessment tool using the CAM. Positive, negative, or unable to assess, right? Patients may often be assigned unable to assess when it is inappropriate given the level of sedation or medical condition. The purpose of this study was to evaluate, so there was a study done in Journal of Intensive Care in 2015, and basically they found out that, a large number of people are been inappropriately assessed as positive or negative or unable to assess. And so it's not an uncommon thing. You think it's easy because you go through the questions, but apparently it's more difficult. So there were, out of their study, they had 61 patients, 45 medical, 16 surgical, 27 were mechanically ventilated. So they had 116 documented episodes where they actually went through the CAM ICU score on these patients, and 35% were inappropriate. So, 35% is inappropriately couldn't be assessed when they really should have been able to be by the criteria. So that's 35% of the patients that, were they positive? I don't know, but could they have benefited from some intervention then? Because I figure if they're saying they're unable to be assessed, there's something wrong with the mentation. Otherwise, they'd be clearly able to assess it, right? So there's something going on there, but it's a big problem. So I got a couple more YouTube videos because these really go through them pretty well on how to do it. Hopefully this works.
Utilizing the confusion assessment method for the ICU, otherwise known as CAM. In order to accurately we need to consistently test our patients. It's not an acceptable.
Sorry about that.
Assessment phase.
Oh man. Let me see if I can get this to go louder.
In order to do this, we must select enrichment agitation sedation scale.
Okay,
or
now let me
RASS,
rewind it.
at deeper levels of consciousness, such as a RASS of D.
Okay.
Hello. Today we're going to briefly discuss how to assess your patient for delirium utilizing the confusion assessment method for the ICU, otherwise known as CAM ICU. In order to accurately identify patients as delirious, we need to consistently test our patients. It's not an acceptable option to use patient behavior as your assessment piece. It is very easy to identify hyperactive delirium patients, but we often under-identify the hypoactive delirium patient. We start off by assessing level of consciousness. In order to do this, we must utilize the Richmond Agitation Sedation Scale, or RASS. At deeper levels of consciousness, such as a RASS of -4 or 5, it is difficult to test them because the patient is not responsive. In this situation, we do not conduct the CAM ICU and refer to the patient as unable to assess. This should occur very infrequently. Once you've determined that your patient is testable and has a RASS of greater than or equal to -3, you move on to assess content of consciousness. To assess content of consciousness, you must follow the CAM ICU algorithm. Start with feature 1. Has there been an acute change from mental status baseline, or has the patient's mental status fluctuated in the last 24 hours? To answer the first question, we must take into consideration the patient's pre-hospital mental status. You can get this information from family, friends, or the H&P. If no one is available to help establish what the patient's baseline is, use critical thinking skills. If the patient is young, which can be considered less than 65, and is admitted from home with no documented neurocognitive disorder or history of stroke, then you could assume that the patient has a normal baseline mental status with a RASS of 0. If the patient is older, has documentation of a stroke or dementia, or came from a nursing home, then you can assume that the patient's pre-hospital baseline may not be a RASS of 0. Always use the patient's baseline mental status for each successive CAM ICU assessment. If your patient has not had a change from their mental status baseline, and their mental status has not fluctuated in the past 24 hours, then you can stop. And note that your patient is CAM ICU negative and not delirious. Now remember, alteration in mental status includes those that are chemically induced by S, including fluctuation due to titration of sedatives. This is not the patient's usual mental status. So, if the patient has had any fluctuations in their RASS during the previous 2 shifts, they have had a fluctuation in mental status, and you would move on to feature number 2. Feature number 2 assesses for inattention. When completing this assessment, say to the patient, I'm going to read you a series of 10 letters. Whenever you hear the letter A, indicate by squeezing my hand. Read the following 10 letters in a normal tone, loud enough to be heard over the noise of the unit, at a rate of 1 letter every 3 seconds. Remember, patients with ICU-acquired weakness or other neuromuscular diseases may require more time to respond, or indicate response with another method such as eye blinks or finger taps. When scoring the patient, errors are counted when the patient fails to squeeze on the letter A, as well as when the patient squeezes on any letter other than A. If a patient has any movement or eye opening to your voice, but does not squeeze at all, or does not stay awake long enough to squeeze for more than 1 letter, then this patient is obviously inattentive, and you move on to feature 3. This also applies to a patient who is agitated with a RASS of +1, +4, and therefore not participating in assessment or comprehending your instructions. If your patient makes less than 2 errors, then you can stop and note that your patient is CAM ICU negative and not delirious. If your patient makes more than 2 errors, proceed to feature 3. Feature 3 asks you to once again identify the RASS level your patient is currently at. If they have a current RASS level of anything other than 0, which is alert and calm, they're considered CAM ICU positive and delirium is present. If they are a RASS level 0, then proceed on to feature number 4. Feature 4 is where we assess disorganized thinking. This is often where we identify those patients with hypoactive delirium. They've been calm and cooperative, not demanding much attention, but when really tested, they have disorganized thinking and are delirious. Patients are asked to answer 4 questions as well as follow 2 commands. Begin by asking question number 1. Will a stone float on water? Give them time to think about it and respond. If at any point in time they make more than 1 mistake, you may stop assessing them and identify them as CAM ICU positive and delirium is present. If a patient cannot move his or her arms, or is blind, score solely on the questions and skip the commands. In that case, feature 4 would be present if the patient misses more than 1 question. Though it is challenging, you can perform the CAM ICU on dementia patients. The features of delirium are identifiable even in the presence of dementia. A good question to ask the family is, do you think he or she could do this test at baseline? If the family does not believe the patient could be tested, then the patient is considered unable to test. In order to facilitate testing on all patients, the RAS and CAM ICU algorithms will be hung in each patient room in both the ICU and the IMCU. This tool will help prompt you through the delirium assessment process. All ICU and IMCU patients must be assessed for delirium at least once a shift. I hope this has been helpful for you. Thank you.
All right, so that was a quick walkthrough. I think it was pretty thorough. Everyone's doing it like that? Yeah, okay. No, I don't doubt that you're doing it. Yeah, it's, the EMR documentations are all sucky and yeah.
But it's in, you know, if you have a website.
And then do you have somebody, when you get a positive one, you can tell and they care? That's the other problem. Okay, I mean it should be. I mean it should be becoming more and more in the forefront now because it's become so publicized.
Like you said, it's not just being used really in the ICU, it's being used in geriatric,
Yeah.
those going to surgery, you know, pre-risking them to see. It's come a long way from the Richmond agitation and sedation scale.
Hello. Today we're going to briefly... Hello.
So I have a video that has some people going through it actually. I mean, do you guys want to see that or you just want to move on? I mean, that shows them actually doing it on a patient, although they're, well, I won't make any comments, but it's, if you've never seen it done, like, you know, I've seen the nurses doing it, but it'll show jazzy rhythm too.
This will be a demonstration on how to perform the CAM ICU assessment. To properly treat delirium, early recognition is essential. The patient's health history should also be evaluated for delirium risk factors, such as dementia, alcohol abuse, and drug abuse, hypertension, coma, high severity of illness, and use of benzodiazepines. CAM ICU assessment has 4 separate categories to test: acute onset or fluctuating course, inattention, altered level of consciousness, disorganized thinking. For acute onset or fluctuating course, the RN will assess the patient for any acute mental status changes from the patient's baseline or any mental status changes within the past 24 hours shown by changes according to the RAS scale. What was Cole's baseline mental status prior to being admitted to the hospital?
He was normal, usually has a calm manner, very outspoken and outgoing.
Okay. Has the patient had any fluctuation in mental status in the past 24 hours, as evidenced by fluctuation on the sedation level or consciousness scale? We will be using the RAS scale. Yeah, A0.
The patient in situation 1 would receive a score of 0 because his current mental status is the same as his baseline and has not fluctuated in the past 24 hours. The patient would score a 2 if his mental status had been anything but baseline. Please know that in this category, the patient's score will either be a 0 for passing or 2 for not passing.
For inattention, say to the patient, I'm going to read you a series of 10 letters. Whenever you hear the letter A, indicate by squeezing my hand. Read letters from the following list. I will now show a patient who passes this section and a patient who does not pass this section. I'm going to read you a series of 10 letters. Whenever you hear the letter A, indicate by squeezing my hand. S, A, V, E, A, H, A, R, T. When you hear the letter A, indicate by squeezing my hand. S, A, V, E, H, A,
For inattention, patient 1 receives a 0 because the number of errors are less than or equal to 2. Patient 2 would receive a score of 2 because the number of errors are greater than 2. The score in this category will either be a 0 for passing or 2 for not passing.
For altered level of consciousness, the RN will assess to see if the patient simply falls under any other number on the RASS scale other than 0. First patient is a RASS of 0. Second patient is a RASS of anything but 0.
For altered level of consciousness, patient 1 receives a 0 because his RASS is a 0. In situation 2, the patient would score a 1 because his RASS was anything but 0. In this category, the patient will either score a 0 for passing or a 1 for not passing.
For disorganized thinking, the RN will ask a series of yes or no questions and have the patient follow a command. And if the patient makes more than one mistake, they fail this section as well. Cole, will a stone float on water? No. Are there fish in the sea? Yes. Does 1 pound weigh more than 2 pounds? Can you use a hammer to pound a nail? Good. Now it's the command. Hold up this many fingers. Okay. Do the same thing with the other hand. Now, if the patient is unable to do that with the other hand, just say, hold up 2 fingers, and then add 1 more. Cole has passed step 4. Cole, can you tell me, will a stone float on water? Are there fish in the sea? Does 1 pound weigh more than 2 pounds? Can you use a hammer to pound a nail? Hey, Cole, can you hold up 2 fingers for me? Can you do the same thing with the other hand?
For the last category,
Brilliant acting.
the patient in situation 1 scores a 0 because his combined number of errors are less than or equal to 1. The patient in situation 2 would score a 1 because his combined number of errors were greater than 1. In this category, the patient will either pass with a score of 0 or not pass with a score of 1. After your assessment, score the patient. A total score of 5 points or more is considered a positive CAM-ICU assessment, and delirium is present. If the patient scores less than 5 points, it is considered a negative CAM-ICU assessment, and delirium is not present.
Okay, everyone's good with that? Do stones float? Okay, so then we have the common conundrum of now we all know what delirium is and everything else, but we have to convince the other people that they're incorrect when they're telling us, oh no, the patient just has, this other disorder, right? So you're going to tell the team that I think, what was his name, Cole? Cole has delirium based on his CAM-ICU score of 6 or more. And then basically they're going to say, oh no, I think he just has dementia. Yeah, he has dementia, and it's nothing, and that's how he is. And so you have to differentiate between delirium and a psychiatric disorder. So if you have clouded consciousness or decreased level of alertness, disorientation, you have to look at the acuity of onset, like we said. This is a rapid onset, right? Fluctuating course. Age greater than 40 without psych history, presence of risk factors for delirium, right? These are the people that we're going to say are more likely to have delirium than a psych disorder. So, dementia never developed overnight. So, it has what they call an insidious onset. These patients with Alzheimer's dementia, they don't all of a sudden go from driving to being bedbound all twisted up, right? So gradually established chronic memory and executive function disturbances. It does not fluctuate for the most part, maybe a little bit here and there, but for the most part they're going to be steady from the moment you meet them to the time they leave. But in delirium, we said the cognitive changes develop acutely and they fluctuate. So they may eat breakfast, and then at lunchtime they don't know who you are anymore or why they're there. They're trying to get out of bed. Dementia has intact alertness. They could be awake and alert, but they have dementia. They won't be able to speak and think properly, but they may be looking around just like awake and alert, correct? So there's where we have to make our determination, you know, because, I mean, how many times have you been told that the patient, it's dementia, and it's dementia, and it's dementia. Meanwhile, the patient, the family comes and they tell you, well, last week they were at a wedding and they danced with their granddaughter and everything was, you know, they made the speech, whatnot. Now they're, you know, can't find the words, they can't say anything, they can't do anything, they're ripping everything out, and the family's beside themselves trying to figure out, you know, but everyone else is telling them, well, you know, they have dementia now. So you have to, you know, advocate for the patient, let them know that this is something that can happen to patients who are in this situation, as we all know. Reversible, right? Usually. Schizophrenia versus delirium. Schizophrenia rarely onsets after 50. They get auditory hallucinations, whereas our delirium friends, they can get auditory hallucinations too, but you know, it's primarily visual disturbances, visual hallucinations. Memory is grossly intact if you have schizophrenia. Speech is fine. They may be paranoid and, you know, very suspicious of everything you do, and they may actually, you know, try to convince you of things that aren't real, but they are not garbled and misspeaking and fading off in the middle of the sentence like I am. No wide fluctuations over the course of a day, so you don't have a schizophrenic who in the morning is schizophrenic and in the evening is not schizophrenic, so they're going to be relatively stable. Mood disorders. So, you know, you could be, you say, how come the guy with the, who's ripping off all the stuff in the beginning says, I want to get out of here. How do you know he's not, you know, bipolar and he's going through a manic phase, right? Again, you know, this is not the first time you manifest a mood disorder is when you're in the hospital 85 years old. So there should be some history of that before you say that that's what his problem is. You know, the cognitive performance is not impaired if you're having a manic episode. Actually, some of those people, when they have their manic episodes, are highly productive. You know, they work on things for hours at a time to the middle of the night. And, so they'll have a flight of ideas, you know, but they'll have some coherence to it, not like the people that we come across with these new onsets of delirium. So, for treatment, we're going to try and eliminate the causes, and we went over the causes in the beginning, and there's like a million, right? But I think if we stick to the basic things, we'll get like, you know, 80%, I hope, of the problems, you know. Underlying illness. If the patient has a UTI, or sepsis or something, we're going to treat that, and hopefully that will help improve the patient's condition. Obviously, we're going to try to treat that anyway, right? But then, I don't know, how many people have a ICU pharmacist working with them? Anybody? ICU pharmacist or somebody that goes over the meds with you, and we do, right? And so, but you want to just basically, even if you don't, you want to look at the basic, the pain medicines, the narcotics that they're getting around the clock, the benzodiazepines that they've never taken before, but now they're taking them a lot. And the more agitated they get, the more they keep getting, and it's like a cycle, right? Until they're unconscious. Mission accomplished. And then, so if you go with treating the basic illness, right? Looking for medications that are simple, like the morphine and the Dilaudid and the benzodiazepines. You put other things there too, but I think that you will have a pretty good start on this kind of thing. You start working down the ladder with some of the other ones also, if those turn out to be nothing. But also there's some simple things that, you know, we can give, instead of benzos, Haldol has been shown to show some improvement in patients who have delirium. Like on a scheduled type basis, and also Seroquel to help them sleep at night and get back on their rest, their nighttime sleeping cycle, because half these patients are up in the middle of the night in the ICU, and they're sleeping during the day, and they get all disoriented. Everyone's ICU have windows in either of the rooms. Are the beds facing the windows? So, they lose the day, night, and things, and so you're pointing toward the middle, like ours are, and the window's behind them.
Now you have curtains with the scenery so they can see an outdoor scene and people can see it.
We did that too, yeah. But it's not like a Long Island scene. It's like an Arctic kind of winter. Yeah. Actually, we have some rooms in our step down that actually on the third floor, they look out over the harbor. So they're actually water view rooms. They'd be very expensive real estate. But the patients' beds are facing the other way. So I often go down there and I say, hey, when you get up out of bed later, why don't you turn the chair on? You can look out the window, especially in the winter when all the trees go away. But the majority of the rooms are facing, the beds facing away from the window, yeah. So they lose day-night differentiation. So Haldol, Seroquel at night, just introduced little by little. Don't start off with the highest dose ever. And there are some other non-pharmacologic things. I don't know, is anyone addressing non-pharmacological things like having a clock, having the windows, reorientation of the patients to where they are, why they're there, glasses, hearing aids, dentures, these kind of things, removing Foleys. These are things that, getting the patient the TV channel that they like or the music that they like can potentially help. So, if we take care of these patients, they can resolve quickly sometimes, but they can come back. So I just had a patient's father who came to me just today, actually. His son was in the ICU, very ill, also a substance abuser and an alcoholic, but he's in his 50s or so, and basically he came in with severe acidosis and renal failure and things like that. He got better from that, and last I saw him, he was still on a respirator. He was liberated from the respirator, he went to the floor. But the father came to me today and said, my son, they think he has dementia. He's in the dementia ward at the nursing home now. And so it's funny because he also told me that, my wife had dementia. Initially they thought she had dementia, but it was really this ICU delirium, he tells me. He says, it was really this ICU delirium, and I worked with this doctor, Eli, from Vanderbilt in Tennessee. And I said, really? He said, yeah. And then she was one of the original study participants in the studies that they were doing on delirium 20 years ago down in Vanderbilt, which I thought was kind of coincidental because I was coming here today. But I said, okay, give him my number if he wants to call me. We can chat about it. But, it's easy for this. So I try to figure out ways now to try and get this guy back to the hospital because from what he was telling me, they're just medicating with psychiatric meds now. And I can't tell what's 100% from the guy, but because of the older gentleman, and he's telling me kind of the things that he wants to tell me. But, I can see that it's probably may not be too far off that this guy went through this horrible ICU thing with his heroin addiction and his alcohol addiction and his Suboxone and his pain meds. He got off the respirator and he was on the floor, and they said, you're medically cleared to go now. And they sent him to a rehab center where he didn't rehab very well, and now is in like the father told me he stood up in the cafeteria and peed on the floor. So then he went to the dementia ward. Because obviously the first time dementia is you stand up in the cafeteria and pee on the floor. And so, this is something that's real. This really happens to real people that we take care of. And so I'm hoping that we can get some of these things going across all of our ICUs. And now, there's even a move to do some of these things on med-surg floors because the same thing can happen to patients there. So the patient leaves the ICU. We were getting them out of bed every day. We were doing this, ambulating them 100 feet. They go to the floor, and they have different staffing ratios, and they have different things that they consider important. Now the patient doesn't get out of bed again for another week. The patient gets delirious again, so we have to make a continuum where, and I don't know how it is where you guys are. It may be the same, it may be different, but the nursing ratios are like 1 to 8 or something like that rather than 1 to 2, and they really can't do all the same things that we can, but it needs to be identified. Yeah, but you can see how it can happen to a relatively young guy who he's going to be in a dementia unit now forever. Unless we can figure out some way to get him taken care of. So some older patients may not return to baseline. So we got to let the families know. And anyone here have UpToDate or, UpToDate usually has a lot of printable family things in there. But also, what is it, ICUdelirium.org or something? It's something. It's the Vanderbilt website. I think it's ICUdelirium.org. Has all printable family things that you can print out about what delirium is, and I've given that to a few families, and they've understood, and they've brought the glasses, they've brought the dentures. They thought they'd bring the hearing aids and things home because they didn't want to get lost. Meanwhile, the patient's eating like a mush food now because they don't have any teeth and they can't hear a damn thing you're saying, and they're getting all confused. So it helps them become involved and help the patient get better by them reorienting and understanding what's going on and that they can help. And that's the F in the A, B, C, D, E, F, right? Just keep adding on. Does anyone else have family involvement programs that with the patients, like kind of mobilizing the little care kits and things like that they can help out with? Okay, so we want to let the families know that this is something that occurs and it's not uncommon, and they can participate and help the patients get better by reorienting them to why they're there, what the day is, what time it is, what, you know, that they had a procedure, that they're going to get better, and, you know, general encouragement. Let the nurses know what the patient likes, what kind of person they are, a little bit about their history and things. They're into baseball, you can talk to them about baseball, things like that. Get a little back to their home type of scenario and the things that they're used to talking about. And, you know, they may be very upset, and I've had families that were like, this is not my dad, this is not my, they can either get very angry and go to administration and yell, or you can explain to them and let them know that this is something that does occur. So this is the last video, but it's really wacky, and if you look at this as how delirium might be,
a hospital environment designed to be elder-friendly will reduce and prevent delirium. Some simple changes include large, easy-to-read room numbers and other strategies to help patients find their way around with less confusion. Bathroom mirrors low enough to be seen from a wheelchair encourage self-care and independence. Newspapers, calendars, and clocks help with orientation and engagement in daily life.
Hi, Gord. It's Donna.
I'm your nurse today. Do you remember me?
I've been looking after you all morning. The most important thing a nurse needs to do when she's calming a delusional patient is to be reassuring and calming. How are you feeling? Not so good? Take a minute. Wake up. To provide a restful environment with a minimal of distractions.
It's lunchtime. I'm going to have something to eat.
The person might need to be fed because for the time being they've forgotten how to do that.
I'm going to sit you up on the side of the bed.
And most of all, don't argue with their delusions. If they think there's a snake on the foot of the bed, all they really need to know is that you're going to keep them safe and take care of them. One of the things that we often find with our older adults, if they do become delirious, is they'll pull out their tubes. So we do not use Foley catheters. We avoid them. If a patient cannot void, we will do in and out caths. We try to get them up to a commode at the minimum and get them to void. They empty their bladder. We don't have as many urinary tract infections because the bladder is totally empty. There's not that little residual that's left there. Also, that getting up and down really helps to ambulate the patient, get circulation going, get oxygen to the brain, and keep them orientated. It's also a normal function, so we try to create normal functions. With our intravenous, we often will have an infuser plug put in, so if they do remove it, often it's not the site that we have lost, but just simply the tubing. We also try to get them hydrated quite quickly so we can get rid of that IV.
Now, why don't you take a sip of apple juice while I start to open your containers for you?
Okay. That's a Blair Witch Hospital. So, I mean, if you imagine that that's what the patient's seeing when they're trying to, like, grab you and, like, pull things out, it makes it a little more understandable than just that guy's an ass or something, you know. You want to first be thinking about the fact that they may be experiencing something like that, and it's horrible, and, you know, compassion and empathy prior to yelling and screaming.
A hospital environment.
All right, so got a couple cases here. How long do you want this to go on for? Because I could go for another hour or two. That's my wife.
Do you want to do like one case study and
Sure.
then open it up to questions?
Actually, let me just see what's beyond this. My memory is failing me at the moment here. Let me see what's back here. Oh, that's all. Okay, good. All right, so case one, Mr. E is a 71-year-old gentleman with a history of asthma, BPH, hypertension, been to medicine 3 days ago for bilateral lower extremity cellulitis. At the time of admission, he was cooperative and oriented, but over the past 24 hours has become occasionally confused, agitated, uncooperative, and somnolent. He appears to be talking to someone in his room when no one is there. So, at the time of admission, he was cooperative and oriented, right? So, obviously, this is something that just over the past 24 hours become delirious. He's having hallucinations, yeah. His meds, lisinopril, naproxen, cimetidine, albuterol, tropium inhaler, levofloxacin, oxygen via nasal cannula. No known psych history. Drinks 1 to 2 glasses of wine per night. The medicine service is concerned he is psychotic. And see, it's requests help managing his behavior. When you speak to him, he is difficult to rouse and falls asleep several times. He struggles to maintain focus on questions and is unable to perform the mental status exam. He believes he's in Oklahoma and that you are his cousin. So what points to delirium? He has altered mental status that developed over the 24 hours that he'd been there, right? He was perfectly fine. Agitation, alternating with confusion and somnolence. Auditory hallucinations in an elderly male that didn't develop schizophrenia overnight, right? So several of his meds could also be causing problems. So, yeah, and then also, hypoxia, you want to make sure, I mean, if he was on a monitored floor, you would see if he was hypoxic or not, but on the med-surg floors, you never can tell unless you put a pulse ox on. So some of these meds could be causing, like we said, the actual infection itself, UTI, light abnormalities, alcohol withdrawal, 1 to 2 glasses of wine a night. Doesn't seem like that much, I guess, but I guess some people, it could really, if they've been drinking 1 to 2 glasses of wine a night, that's what they tell you, right? Okay, so thank you for your attention. Anyone want to tell about any experiences they've had, or make any comments or thoughts about things that we could try to do to improve our situation here with the delirium?
I think it's
Oh, got somebody over there.
I've seen recently some providers using precedents in this situation. I mean, have you experienced using that, or what are your thoughts?
So, I don't believe that it is FDA approved for that, nor is it approved for alcohol withdrawal. Anyone here using it for alcohol withdrawal? Yeah, so I don't think it's approved for alcohol withdrawal either, but it works because it hits some of the same receptors that we're questioning here. And so I can't say that I've used it directly for that, but I do know that people are using it. It's exorbitantly expensive though, and I don't really know what the end point is with it because, well, I guess if the patient snaps out of the delirium, how long do you use it for usually? Like several.
You've been using it a lot more when they're extubated, like if they've been on propofol or something.
Right.
you
Okay.
want them-
Kind of like transition them off it.
Yeah.
Hey,
Transition them to something oral, I don't know.
we'll do that sometimes in patients who have difficult extubations because when you stop the Diprovan, they're flailing around and stuff. So maybe in that regard we are using it. I'm not really assigning it that way, but yeah. So we do use it a lot, mostly for alcohol withdrawal, though, and for these difficult patients who are poorly cooperative when we try to extubate them with Diprovan. But I haven't said, oh, this guy has delirium, let's put him on Precedex, for example. But it may be something coming that way. Was there something up front?
No, I was just gonna say, I think it's important, like the pre-history, when the patient arrives, to get like as much of a good history that you can, so as they develop, if they go along their path in ICU, what
Yeah.
happens, and that's, you can look back and say, oh, look, he was fine. He plays ball every weekend, he plays golf, he does this, and now he's, like that.
But you'd be surprised how many times you hear people say, oh, I think he has a little delirium. It's like, you know him from home?
Yeah.
No.
Really tough families, yeah.
Or no, I'm sorry, say you have a little dementia. And I'll say, you know him from home? And they'll say, no. And I said, how do you know that then? He didn't have it when he came in, but it's not in his history. But, it sounds like a logical thing to say the patient it's just a little dementia, an older person, you know, and you can picture it. But this, if it's delirium and we can identify it and we can treat it and we can improve the patient, that's the goal, you know?
Yeah.
Thank you.